Hi everybody, this is Miss Poindexter. We're going to talk about perioperative nursing today. Objectives: know the role of the nurse in the 3 phases of perioperative care. The role of the nurse with informed consent. Identify the comorbidities that impact a patient's perioperative care and discuss why. And know the role of the nurse as it relates to surgical asepsis. Your materials are Chapter 5 in Honan, which is great as a resource and additional reading. ATI Skill Module Surgical Asepsis is good for your OR rotation. The ATI MedSurg Nursing 10th edition, chapters 94 through 96, focus on these for testing purposes. So first things first, know your population, your elderly, those over 65, even if they're in good health, just the normal progression of age on organs can have an effect of how they respond to anesthesia. Obese patients, fatty tissue makes them more susceptible to infection. Also, the additional weight on the chest can cause some respiratory issues, and that additional weight can make recovery difficult in terms of moving. Patients with disabilities, these include things like intellectual disabilities and visual and hearing impairment. So make sure when you do a handoff that you report this information to the nurse receiving them. Smokers are slower to heal and can have respiratory issues. Diabetics are at risk of infection and slower to heal. So see box 5.2 for additional risk factors. So perioperative nursing begins once surgery has been decided and agreed upon and ends once the patient enters the OR suite. Understand a patient's history. These are going to be things that focus on risk factors that can be complications for surgery. You need to look at a patient's current medication and over-the-counter medications. Pay particular attention to any herbals, because sometimes patients don't think of these as medications. A good rule of thumb is that a lot of herbals that start with the letter G, that could be ginkgo biloba, garlic, ginseng, all increase the risk for bleeding. Also, if a patient has any bleeding disorders, history of MH or malignant hypothermia, any allergies, and any diseases that could affect how they manage anesthesia. This is both cardiac and pulmonary. And of course, pregnancy status in those that are of childbearing age. Hold anticoagulants for 7 to 10 days prior to surgery. That includes warfarin or aspirin. No lab work, any labs that relate to bleeding and heart, like potassium, would be beneficial to know, and kidney function, like creatinine and BUN. Pre-surgical testing or procedures, make sure that they are done prior to the patient going to surgery. Also, any prep that is needed depending on their surgery, whether this is bowel prep, HIPAA cleanse, shaving, IV placement, or nail polish removal. What medications are being ordered to administer beforehand. Big thing, make sure that a patient is NPO or nothing by mouth. And when you ask this, you need to also inquire to make sure they haven't chewed gum or sucked on any hard candies. Why do you think that is? Think about what that does to the stomach acid. Also, there needs to be an updated H&P on file. It usually needs to be updated within 24 hours of surgery. And know your role in informed consent. So informed consent is basically the responsibility of the provider or the surgeon to obtain consent after discussing the risk and benefits of the surgery or procedure. The nurse can clarify any information. The nurse can witness the signing of the consent form after the provider has obtained consent to treat. Informed consent is needed not just for surgery, but for electroconvulsive therapy, certain medications, seclusion, restraint, and again, any invasive procedures. Patients can only sign a consent if they're 18 years or older, mentally capable, not under the influence of medication that can affect judgment. Once it has been obtained, documentation, you need to reinforce of information given by provider, any irregular occurrences, and if the use of an interpreter was needed. And when I say interpreter, I don't mean the patient's husband or mother. It usually needs to be an interpreter that has been trained and certified and is typically an employee of the hospital or a contractor by the hospital. When we're looking at patients that are not under the influence of medication, that typically would be say a patient comes in pre-op, they're nervous, they decide to give them some medication to relax them. They need to get consent, need to have the consent signed before that medication is administered. Some patients who are unable to give consent, if they're incapacitated and there is no one that has power of attorney over them, then typically two doctors would have to do implied consent for them. Also use some common sense when it comes to patient allergies. I love this cartoon because a lot of times when I used to do surgery, sometimes I would see on the timeout board that a patient would say have an allergy to cats. I don't know of any time when I've seen a cat in the hospital, let alone a cat in the OR suite. The intraoperative phase basically begins when the patient is transferred into the onto the OR table and ends with admission to the PACU or sometimes directly up to the floor. So there's a handoff before leaving pre-op. At that time, a lot of times the nurse who is receiving the patient to take them into the OR is known as the circulating nurse. At that time, they will verify that the consent has been signed. They will verify with the patient. They will ask them what type of surgery they're having. They will also double check the labs, see what medications the patient has received, and any allergies they may have. The big role of a circulating nurse is patient advocacy, in terms of making sure that everyone in the surgical team is aware of patients' allergies. They take part in the positioning, maintaining dignity of the patient, help with cutting back the risk of hypothermia, since rooms are typically kept at a cooler temperature. And why do you think that is? Once you think about it, think about bacteria. Do they like a cold environment or a warm environment? So typically trying to keep patients warm with warming blankets. Understanding the MH protocol for malignant hypothermia. Know where the crash cart is and how to use it. Also, there are different types of sedation and knowing their side effects. One in particular that you need to understand is local, which is spinal and epidural. The biggest risk is spinal headaches with those. Aseptic technique, we'll talk a little bit more about. Patient prep. Taking part in what's called a timeout. Doing instrument and sharp count. And of course, documentation. So we're going to watch a short little video here about timeout. And it gives you kind of a good idea of what happens. This is basically what we call a pause before the surgeon makes incision. When the patient is already prepped, there's basically a rundown and overview of the patient, the surgery that's about to happen, any complications, any concerns or considerations. All this needs to be done before surgery starts. Everybody in the room has to agree. If there's any problems, then basically surgery will not commence. So this is just a short video to show you what a timeout looks like. And I can tell you, if you go into any OR suite, they are not this detailed. But honestly, they really need to be because it really helps with advocating for patient safety.
Is everybody ready for a timeout?
Yes.
Yes. Okay. Carrie Rosencrantz, surgery.
Cam Clark, anesthesia.
Kelly Carey, scrub nurse.
Pat Stockwell, circulator. The patient is Betsy Smith. She was identified on the way in, correct?
Correct.
Yes. We are planning to do a left mastectomy and sentinel lymph node biopsy. She has a green circle marking the left side. She is appropriately positioned supine. Site, as I mentioned, is marked. She requires no blood products.
Correct.
Cam, allergies.
She has a severe penicillin allergy, and because of that, we've chosen vancomycin as her antibiotic, and that started at 9:30.
Thank you. She is wearing Venadines, Pat?
Yep, and they are turned on.
Thank you. Images are left-sided and they have been confirmed. Pathology, we will have 2 specimens at least. The mastectomy will go directly to pathology. We may have frozen sections on the sentinel lymph nodes.
Okay.
Special equipment, implants, and irrigation fluid. The gamma probe is in the room, correct?
Yes.
And it has been checked.
Yep.
Kelly, medications on the field.
I have xylocaine 1% with epi 1 to 200,000, 30 mLs, expires 3/13, and I have normal saline as well.
Thank you. Cam, any anesthesia or airway concerns?
She's otherwise healthy, had a normal airway. She is at a high risk for post-op nausea and vomiting, and if there's no contraindication to dexamethasone, I would be giving her full prophylaxis.
Dexamethasone is fine with me. Thank you.
Thank you.
She is full code. Does everybody agree?
Yes.
Yes.
Any special issues or safety concerns?
Not otherwise.
Just a reminder, Pat, the nodes should go labeled radioactive to pathology.
Okay.
Yep. Any other safety concerns?
No.
Is everybody okay?
All set?
Yes.
Okay. Thank you.
Thank you.
Let's go.
So the person that you saw in green that had the glasses, that was the circulating nurse. Obviously, the one talking was the actual surgeon leading the timeout. The other gentleman, he was the anesthesiologist, and the other woman who was to the left, she was a surgical tech. So malignant hypothermia is acute and life-threatening. Basically what happens is a person goes into a hypermetabolic condition or state, causing alterations in the calcium activity of the muscle cells. What it leads to is muscle rigidity, hyperthermia, and damage to the central nervous system. The problem with malignant hypothermia is that a person could have, say, 5 surgeries with absolutely no complications, and the 6th surgery, for whatever reason, this is triggered. The agent that actually causes the issue is inhalation of anesthetic agents and celecoline, or a lot of times you just hear it called as sucks if you're in the OR. The treatment, basically, once the surgeon, and especially the anesthesiologist or the nurse anesthetist who is monitoring the patient, will start to see certain changes. What they will see is an increase in temperature. They will see the heart rate start to go up. They will see a decrease in urine output, and also with the muscle rigidity. So really, the treatment is to give them IV dentraline, which is basically a muscle relaxant. It takes 2 nurses to basically mix and administer. So the moment that there's suspicion, surgery has to be stopped. So it's not one of those things of, oh, we can kind of continue on. No, surgery must stop. Administer the IV dentraline, provide the patient with 100% O2, obtain ABGs, which is arterial blood gases, start infusing iced IV normal saline, start putting cooling blankets on the patient, and if a catheter is not in, a catheter needs to go in to monitor a patient's I's and O's. This can be life-threatening. If a patient is successfully treated, they typically will have to spend some time in ICU for observation to make sure that there is no damage. Malignant hypothermia can be hereditary. Patients who have a family history of malignant hypothermia typically will be the first case of a day, and they will just need to stay away from using inhalation anesthesia. Spinal headaches is a complication. It's usually caused by a cerebral spinal fluid leak from spinal and epidural local anesthetics. And it manifests when the head of the bed is elevated. So what you need to know is the treatment. So if a patient has a severe headache following spinal anesthesia, you need to keep the patient flat to promote the duroter to seal, keep them in a quiet environment, and hydrate the patient to help replace the CSF loss. Surgical asepsis, you learned last semester, but basically what you see here, and oddly this is kind of a bad picture, but anytime somebody has their back turned to the sterile field, anything behind them at that point then should be considered unsterile because they've basically taken their eyes off it. But however, I digress. The areas that are considered sterile are going to be above the waist, all the way down to the hands, so all this green area, and obviously, again, above the waist in terms of the patient up here. And I can tell you a rule of thumb too in an OR suite is sometimes when somebody's busy, they may contaminate themselves. They might not have realized it, but it's the responsibility of everybody in the OR suite to basically notify somebody. So if I saw something and I said, hey, Dr. So-and-so, I just saw your hand, hit something, there shouldn't be any argument. They basically should step back, have the gloves removed, and be re-gloved. Because again, it's all about patient safety. So understanding the different zones, real quickly, there are unrestricted zones, semi-restrictive zones, and restrictive zones. Your unrestricted zone is going to be, say, like pre-op and the staff lounge. This is where people who are in street clothes may walk around. The semi-restricted zones here, you need to be in OR scrubs and wear a cap. So this can be the clean core in the hallways past the unrestricted zone. The restricted zone is going to be the actual operating room. At this time, you'd have to have OR scrubs, also a cap, an OR jacket, goggles, and a mask. Unfortunately, if you do an OR rotation, you will find a lot of people do not wear eye protection, but certainly they should have on a cap and a mask. Technically, they really need to be wearing jackets because skin that flakes off puts basically a sterile environment at a higher risk of infection. But again, this is something that you don't see all the time. Post-operative nursing begins when the patient is admitted to the PACU, which is called the post-anesthesia care unit. Frequent nursing assessments are vital. You need to make sure there's a patent airway. The head of the bed needs to be 15 to 30 degrees unless contraindicated. If somebody has decreased level of consciousness, they should be put in the lateral position. The reason for this is if somebody is having some difficulties, they're kind of going in and out of consciousness, and let's say they're nauseous but are unable to articulate this, and they start to vomit, they're going to put themselves at risk of aspiration if they are in a supine position. So unless it's contraindicated, those patients should be in a lateral position. Watch for hypertension and shock anytime if there's been blood loss of 500 mLs or more. should indicate replacement if it was not done in the OR. Typically, labs should be drawn to indicate also if replacement's needed. Hemorrhage, again, is going to go along with shock. Hypertension and arrhythmias should be monitored for. Pain and anxiety, nausea and vomiting. Monitor any lines and drains that the patient may have acquired depending on their surgery. And those that are an outpatient, you know what your role is in terms of discharge teaching, which a lot of times have to do with medications and follow-up appointments. And also nowadays, in a lot of outpatient settings, it used to be standard that patients could not be discharged until they voided. That's not always the case depending on the surgery, the age of the individual. They may give them instructions, though, that if a certain amount of time has passed and they have not voided, that they should either call their provider or proceed to the emergency room. Also part of the discharge teaching, too, is looking out for signs of infection, which typically are going to be elevated temperature greater than 104. Some post-operative complications that you need to be aware of, specifically for testing, are the ones that have little stars here. I'm not going to go over them too much because I feel they're pretty self-explanatory, but as a nurse, you should know the signs and symptoms. In some of them, I know there's a lot of interventions, but just kind of notice if there's anything that seems to be more related to what the actual issue is that you should focus on. Here, nausea and shock, signs and symptoms are definitely something you should understand. You will have a decreased blood pressure, an increased pulse, a decrease in urinary output. Patients may be having some lethargy, cold and clammy pale skin, and stupor. So again, shock is decreased blood pressure, increased pulse, and decreased urinary output. Urinary retention, decreased peristalsis, and also hemorrhaging. Some other perioperative complications, just understand those who may be at risk and the different terms. Those who have compromised immune systems using steroids, those with history of lupus, rheumatoid arthritis, Cushing's or Addison's, nutritional deficits, those with hyperglycemia, like uncontrolled diabetics and smokers, wound dehiscence basically is just when the wound kind of comes open, but the muscle tissue is intact, where wound evisceration is actually when the muscle has separated and you see a protrusion of bowel. And I apologize here, this should just be Honan. Common meds you should know, antiemetics. Basically, this helps with nausea and hopefully prevents vomiting. Zofran, Phenergan, and Reglan. Zofran can, in some patients, cause some sedation. Phenergan is more known for it. Reglan is an older drug. It can actually enhance gastric emptying, so for those where that's a problem and is causing some nausea and vomiting, that may be the choice. Patients like that, where Reglan may be an option, are those who are long-standing diabetics and they're already having some problems with peristalsis and gastric emptying, and with surgery, it can sometimes slow down this process even more. Anticholinergics like atropine, this helps decrease the risk of bradycardia during surgery. and vagal slowing of the heart due to the parasympathetic response of surgical manipulation. Some of the adverse effects of it, though, is urinary retention, tachycardia, and dry mouth. Other meds you should know are going to be reversal agents. So vitamin K is the antidote for Coumadin, and protamine sulfate is the antidote for heparin. You'll see this more in surgery simply for the fact, especially vascular and cardiac, they will heparinize a patient during surgery, and at the end they will reverse it. And before I move on, the reason for that is basically to cut down the risk of clotting during surgery. Basic discharge criteria, it depends on the surgery, but a person's level of consciousness, making sure they have stable vital signs, they can drink, they can urinate. Like I said before, it kind of depends on the facility. They don't have any nausea, vomiting, shortness of breath, dizziness, and of course no obvious bleeding. So again, a great resource is the surgical asepsis, especially before your OR rotation. And again, focusing for studying for your test, focus on chapters 94 to 96 in your ATI Med-Surg Nursing 10th edition book. So I hope that has been helpful for you. If you do have any questions, please either email me or post it on the discussion board for test 1.